Hello everyone, and welcome back to another chapter of Advanced Pharmacology. Today we're talking about Unit 7, Psychotherapeutic Drugs, and we'll speak specifically on Chapter 29, Central Nervous Stimulants and ADHD Disorder. So we'll jump right on in. Your central nervous system stimulants, or CNS stimulants, increase the activity of CNS neurons. Most stimulants act by enhancing neuronal excitation, a few by suppressing neuronal inhibition. In sufficient doses, all stimulants can cause seizures. Clinical applications of CNS stimulants are limited. Currently, these drugs have two principal indications: ADHD and narcolepsy. Please note that CNS stimulants are not the same as antidepressants. The antidepressants act selectively to elevate mood and therefore can relieve depression without affecting other CNS functions. In contrast, CNS stimulants cannot elevate mood without producing a generalized excitation. Accordingly, the role of a stimulant in treating depression is minor. Our principal focus is on amphetamines, methylphenidate or Ritalin, and methylxanthine or caffeine. These are by far the most widely used stimulant drugs. So we'll talk on amphetamines first. The amphetamine family consists of amphetamine, dextroamphetamine, methamphetamine, and lisdexamfetamine. All are powerful CNS stimulants. In addition to their CNS action, amphetamines have significant peripheral actions that can cause cardiac stimulation and vasoconstriction. The amphetamines have a high potential for abuse. So, for the prototype drugs, there are several. Please hit pause and take a look. So, we'll start off with amphetamine. The term amphetamine refers not to a single compound, but rather to a 50-50 mixture of dextroamphetamine and levethamphetamine. So your lisdexamfetamine, also known as Vyvanse, is a prodrug composed of dextroamphetamine covalently linked to L-lysine. After oral dosing, the drug undergoes rapid hydrolysis by enzymes in the intestine and liver to yield lysine and free dextroamphetamine. The active form of the drug, if lisdexamfetamine is inhaled or injected, hydrolysis will not take place, and therefore the drug is not effective by these routes. Accordingly, it may have a lower abuse potential than other forms of amphetamine. Bringing us to methamphetamine. Methamphetamine is simply dextroamphetamine with an additional methyl group. So how does it work? The amphetamines act primarily by causing the release of norepinephrine and dopamine, and partly by inhibiting the reuptake of both transmitters. These actions take place in the CNS and in peripheral nerves. Most pharmacologic effects result from the release of norepinephrine. So, its pharmacologic effects in the CNS system, therefore. The amphetamines have prominent effects on mood and arousal. At usual doses, they increase wakefulness and alertness, reduce fatigue, elevate mood, and augment self-confidence and initiative. Euphoria, talkativeness, and increased motor activity are likely. Task performance that has been reduced by fatigue or boredom also improve. Amphetamines can stimulate respirations and suppress appetite and the perception of pain. Stimulation of the medullary respiratory center increases respirations. Effects on the hypothalamic feeding center depresses appetite. By a mechanism that is not fully understood, amphetamines can enhance the analgesic effects of morphine and other opioids. It does have cardiovascular system effects as well, which occur secondary to the release of norepinephrine from the sympathetic neurons. Again, norepinephrine acts in the heart to increase the heart rate, atrioventricular conduction, and the force of contraction. So, excessive cardiac stimulation can cause dysrhythmias. In the blood vessels, norepinephrine promotes constriction. Excessive vasoconstriction can cause hypertension, leading us to tolerance. With regular amphetamine use, tolerance develops to elevation of mood, suppression of appetite, and stimulation of the heart and blood vessels. In high tolerant users, doses up to 1,000 milligrams given intravenously every few hours may require to maintain euphoric effects. This compared with daily doses of 5 to 30 milligrams for non-tolerant individuals, leading us to physical dependence. Chronic amphetamine use produces a physical dependence. If amphetamines are abruptly withdrawn from the dependent person, an abstinence syndrome will ensue. Symptoms again include exhaustion, depression, prolonged sleep, excessive eating, and craving for more amphetamines. Sleep patterns may take several months to normalize once again, leading us to the abuse. Because amphetamines can produce that euphoric effect, they have a high potential for abuse. Psychological dependence can occur. Because of their abuse potential, all amphetamines, including lisdexamphetamine, are classified under the Schedule II of the Controlled Substance Act and must be dispensed accordingly. Whenever amphetamines are used therapeutically, their potential for abuse must be weighed against their potential benefit. So, adverse effects. Again, the CNS stimulation of can cause insomnia and restlessness. These effects can occur at therapeutic doses. Weight loss. By suppressing the appetite, amphetamines can trigger that weight loss. Again, cardiovascular effects. At high recommended doses, or at all recommended doses rather, stimulants produce a small increase in the heart rate and blood pressure. For most patients, these increases lack clinical significance. However, for patients with pre-existing cardiovascular disease, stimulants may cause dysrhythmias, angina pain, or hypertension. Accordingly, amphetamines must be employed with extreme caution in these people. Any patient who develops cardiovascular symptoms while using a stimulant should be evaluated immediately. So, do amphetamines increase the risk for sudden death? Probably not. Sudden death in children on these medications is considered rare, and evidence is conflicting regarding the risk for sudden death. Should children routinely receive an electrocardiogram before using these drugs? Again, probably not, despite a 2008 AHA saying it would be reasonable to consider obtaining an EKG in children being evaluated for the stimulant therapy for ADHD. The AHA developed the statement because 14 children, 5 with heart defects, died suddenly while using Adderall, a mixture of amphetamine and dextroamphetamine. However, given that millions of children have used the drug, the death rate is no greater than would be expected for a group this size. Whether or not Adderall was being used, the bottom line, first, there are conflicting data showing the stimulants increase the risk for sudden death, even in children with heart disease. Second, there are no data showing the limiting the use of stimulants in children with heart defects will protect them from sudden death. Third, there are no data showing the screening for heart disease with an EKG before starting stimulants will be of a benefit. Therefore, it would seem that routine EKGs are unnecessary before starting a child on a stimulant therapy, especially if there is no evidence of the heart disease. However, if there is evidence of heart disease or evidence of hereditary cardiovascular defects, an EKG might be appropriate. Psychosis. Excessive amphetamine use produces a state of paranoid psychosis, characterized by hallucinations and paranoid delusions. Amphetamine-induced psychosis looks very much like schizophrenia. Symptoms are thought to result from the release of DA. Consistent with the hypothesis is the observation that symptoms can be alleviated with a DA receptor blocking agent. After amphetamine withdrawal, psychosis usually resolves spontaneously within a week. In some individuals, amphetamines can unmask latent schizophrenia. For these people, symptoms of psychosis do not clear spontaneously, and therefore psychiatric care is indicated. Acute toxicity. Some symptoms of overdose produce dizziness, confusion, hallucinations, paranoid delusions, palpitations, dysrhythmias, and hypertension. Death is rare. A fatal overdose is associated with convulsions, coma, and a cerebral hemorrhage. So, how do we treat it? Well, hallucinations can be controlled with chlorpromazine, an antipsychotic drug. An alpha adrenergic blocker can reduce hypertension. Owing to its ability to block alpha receptors, chlorpromazine helps lower blood pressure. Seizures can be managed with diazepam. Acidifying the urine can also accelerate amphetamine's excretion. So, its therapeutic use, therefore, in ADHD. Well, that's going to be discussed during the ADHD section of this chapter. Narcolepsy. Narcolepsy is a disorder that is characterized by daytime somnolence and uncontrollable attacks of sleep. By stimulating the CNS, amphetamines can promote arousal and therefore alleviate symptoms. So, there is a black box warning on amphetamine abuse. Amphetamines have a high potential for abuse and dependence. In patients who use amphetamines chronically, withdrawal may occur if use of these medications is suddenly stopped. Methylphenidate and dexmethylphenidate, both of which are nearly identical in structure and pharmacologic action. Furthermore, the pharmacology of both drugs is nearly identical to that of amphetamines. So what is it? Well, your methylphenidate, also known as Ritalin, Metadate, or Methylene, Concerta, Daytrona, or Bifenton, is structurally dissimilar from that of amphetamines. The pharmacologic actions of these drugs are essentially the same. Consequently, your methylphenidate can be considered an amphetamine in all but structure and name. Methylphenidate and amphetamine share the same mechanism of action by the promotion of norepinephrine and DA release, and the inhibition of norepinephrine and DA reuptake. So its adverse effects of insomnia, reduced appetite and emotional liability, and abuse liability. Like amphetamines, methylphenidate is not a single compound. Again, it's a 50-50 mixture of dextro and levo isomers. Methylphenidate has two indications, again for ADHD as well as narcolepsy. So it also has its own black box warning of methylphenidate abuse. Chronic abuse of methylphenidate can lead to a marked tolerance and psychological dependence, with varying degrees of abnormal behavior and possible frank psychotic episodes. Which leads us to the other medication, dexmethylphenidate. Dexmethylphenidate, also known as Focalin or Focalin XR, is a drug for ADHD and is simply the dextroisomer of methylphenidate. Again, as noted, the dextroisomer accounts for most of the pharmacologic activity of methylphenidate. Again, it's a 50-50 mixture of dextro and levo isomers. Accordingly, the pharmacology of dexmethylphenidate is nearly identical to that of methylphenidate. The only difference is that the dosage of dexmethylphenidate is only half the dosage of methylphenidate. Which brings us to methylxanthines. The methylxanthines are methylated derivatives of xanthine, therefore the family name. These compounds consist of xanthine nucleus with one or more methyl group attached. Caffeine is the most familiar member of the family, which will be our prototype. Caffeine is consumed worldwide for its stimulant effect. In the US, per capita consumption is about 200 milligrams per day, mostly in the form of coffee. Although clinical applications of caffeine are few, caffeine remains of interest because of its widespread ingestion for non-medical purposes. So how does caffeine actually work? Well, several mechanisms of action have been proposed, which include reversible blockade of adenosine receptors, enhancement of calcium permeability in the sarcoplasmic reticulum, and the inhibition of the cyclic nucleotide phosphodiesterase, resulting in the accumulation of cyclic adenosine monophosphate, the cyclic AMP. Blockade of adenosine receptors appears responsible for most effects. So, how does it work pharmacologically? In the central nervous system, in low doses, caffeine decreases drowsiness and fatigue and increases the capacity for prolonged intellectual exertion. However, with increasing dosage, caffeine produces nervousness, insomnia, and tremors. When administered in very large doses, caffeine can cause convulsions. Despite popular belief, there is little evidence that caffeine can restore mental function during intoxication with alcohol, although it might delay passing out. Its effects on the heart? Well, it stimulates the heart. When caffeinated beverages are consumed in excessive amounts, dysrhythmias result. Its effects on blood vessels? Well, caffeine affects blood vessels in the periphery differently from those in the central nervous system. In the periphery, caffeine promotes vasodilation, whereas in the CNS, caffeine promotes vasoconstriction. Constriction of cerebral blood vessels is thought to underlie the drug's ability to relieve a headache. In the bronchi, caffeine and other methylxanthines can cause the relaxation of bronchial smooth muscles, and therefore promotes bronchial dilation. Theophylline is an especially effective bronchodilator, and therefore it can be used to treat asthma. We'll discuss that more in Chapter 60. On the kidneys, caffeine is considered a diuretic. The mechanism underlying increased urine formation is likely related to the suppression of antidiuretic hormone in the posterior pituitary. In the reproduction, caffeine readily crosses the placenta and does pose a risk for birth defects, although that risk is considered very low. When applied to cells in culture, caffeine can cause chromosomal damage and mutations. However, the concentrations required are much greater than that can be achieved by drinking a caffeinated beverage. Also, although there is clear proof that caffeine can cause birth defects in animals, studies have failed to document birth defects in humans. Although caffeine-induced birth defects seem unlikely, caffeine has been associated with low birth weight. Accordingly to a meta-analysis reported in 2010, consuming less than 300 milligrams of caffeine daily does not increase the risk for preterm birth. An additional review in 2013 revealed that the restriction of caffeine consumption during the second and third trimester of pregnancy did not affect the birth rate or the length of gestation. Whether a higher dose might increase that risk, however, is still considered unclear. Its pharmacokinetics. Caffeine is readily absorbed from the gastrointestinal tract and achieves peak plasma levels within 1 hour. Plasma half-life ranges from 3 to 7 hours. Elimination is by the hepatic metabolism. So, its therapeutic use. Neonatal apnea. In premature infants may experience prolonged apnea, along with bradycardia. Hypoxemia and neurologic damage may result. Caffeine, as well as other methylxanthines, can reduce the number and the duration of apneic episodes, and therefore promotes a more regular pattern of breathing. Promoting wakefulness. Caffeine is used commonly to aid staying awake. The drug is marketed in various over-the-counter preparation for this purpose. Of course, individuals desiring increased alertness can get just as much caffeine by drinking coffee or some other caffeinated containing beverage. Its acute toxicity. Caffeine toxicity is characterized by the intensification of the responses seen at low doses. Stimulation of the CNS results in excitement, restlessness, and insomnia. If the dosage is very high, seizures may occur. Tachycardia and respiratory stimulation are likely. Sensory phenomena are common. Death from a caffeine overdose is rare. When fatalities have occurred, between 5 and 10 grams had been ingested. So, the miscellaneous central nervous system stimulants. Modafinil, also known as Provigil or Alertec, is a unique non-amphetamine stimulant. which is approved for promoting wakefulness in patients with excessive sleepiness, usually associated with three disorders: narcolepsy, shift work sleep disorder, and obstructive sleep apnea, or hypoapnea syndrome. However, all of these drugs has only three approved uses. Most prescriptions are written for off-label use, including fatigue, depression, ADHD, jet lag, and sleepiness caused by other medications. Investigational uses include ADHD and fatigue associated with multiple sclerosis. The military studied the drug for the use in its sustaining alertness in helicopter pilots and found it superior to a placebo. In clinical trials, modafinil has been moderately effective. In patients with narcolepsy, modafinil increased wakefulness, but only in about 50% of the level seen than in normal people. In contrast, methylphenidate and dextroamphetamine increased wakefulness to about 70% of normal people. In patients with SWSD and OSA, benefits are about the same as those seen in narcolepsy. So how does it work? Well, no one truly knows. The drug does seem to influence the hypothalamic areas involved in maintaining the normal sleep-wakefulness cycle. Also, there's evidence that modafinil inhibits the activity of sleep-promoting neurons by blocking the reuptake of norepinephrine. So, its pharmacokinetics. Modafinil is rapidly absorbed from the GI tract. Plasma levels peak in 2 to 4 hours. Food decreases the rate of absorption, but not the extent. Elimination is by the hepatic metabolism, followed by renal excretion, and the half-life is about 15 hours. Meaning, there are adverse effects. Modafinil is, although generally well tolerated, the most common adverse effects are headache, nausea, nervousness, diarrhea, and rhinitis. Modafinil does not disrupt nighttime sleep. In clinical trials, only 5% of patients dropped out because of the undesired effects. Initially, the drug was believed devoid of cardiovascular effects. However, we now know it can increase your heart rate and blood pressure, apparently by altering the autonomic function. Subjective effects, euphoria, altered perception, thinking, and feeling, are like those of other CNS stimulants. However, modafinil has less abuse potential and is therefore regulated as a Schedule IV substance. Physical dependence and withdrawal have not been reported. Modafinil is embryotoxic in laboratory animals and is therefore should be avoided during pregnancy. In post-marketing reports, modafinil is linked to rare cases of serious skin reactions, which do include your Stevens-Johnson syndrome, erythema multiforme, toxic epidermal necrolysis, and patients should be informed about these signs and these reactions. Swelling or rash, especially in the presence of fever or changes in the oral mucosa, and are instructed to discontinue the drug if these signs or symptoms start to develop. Other drug interactions. Modafinil inhibits some forms of the cytochrome P450 and induces others. So therefore, CYP3A4 may accelerate the metabolism of oral contraceptives, cyclosporins, and certain other drugs, therefore causing levels to decline. Caution is therefore advised. Its preparation, dosage, and administration is available of modafinil in 100 and 200 milligram tablets, and for patients who have narcolepsy, the usual dosage is 200 milligrams a day. For patients with SWSD, the usual dosage is also 200 milligrams per day, and should be taken 1 hour before their shift starts. For patients who have severe hepatic impairment, they should use those 100 milligrams per day or 50% of the normal dose. Dosage reduction may also be needed in the geriatric population. Which brings us to armodafinil. Armodafinil, or Nuvigil, is simply the chemical mirror image of modafinil. It differs in that the R enantiomer has a somewhat longer half-life than the S enantiomer component of modafinil. Otherwise, the two drugs are completely identical. Although, again, armodafinil costs more. Armodafinil has the same indications in improving wakefulness, both in people who have narcolepsy, SWSD, and OSA, and has similar adverse effects, including the potential for rare but severe skin reactions. So they are both considered Schedule 4 substances. So now we can jump to the other side of the spectrum here for attention deficit hyperactivity disorder. Our discussion of ADHD has two parts. We begin by addressing the basic concept, specifically signs and symptoms, etiology, and treatment strategy. And after that, we'll discuss the pharmacology of the drugs used in the treatment. So there is a table here of all the medications that we can give. It's an excellent spot to hit pause so you can see different names, availabilities, their duration, dosing schedule, and usual pediatric maintenance doses. So, jumping into basic consideration. ADHD disorder, or ADHD in children rather. ADHD is the most common neuropsychiatric disorder of childhood, affecting 5% of school-aged children. The incidence is 2 to 3 times higher in boys than in girls, and symptoms begin between ages 3 to 7. They usually persist into the teens and often persist into adulthood. Most, 60 to 70% of children, respond well to stimulant drugs. Your methylphenidate, your Ritalin, Concerta are the agents employed most often. So what are signs and symptoms of ADHD? Well, it's characterized by inattention, hyperactivity, and impulsivity. Affected children are fidgety, unable to concentrate on schoolwork, and unable to wait their turn. Switch excessively from one activity to another, call out excessively in class, and never complete a task. To make a diagnosis, symptoms must appear before the age of 7 and may be present for at least 6 months. Because other disorders, especially anxiety and depression, may cause similar symptoms, diagnosis must be done carefully. ADHD can be subclassified as predominantly inattentive type, predominantly hyperactive, impulsive type, or combined type, depending on the symptom profile. Etiology. Although various theories have been proposed, the underlying pathophysiology of ADHD is only partially understood. Neuroimaging studies indicate structural and functional abnormalities in multiple brain areas, including the frontal cortex, basal ganglia, brainstem, and cerebellum. Regions involved in regulating attention, impulsive behavior, and motor activity. Several theories implicate dysregulation in neuronal pathways that employ norepinephrine, DA, and serotonin as transmitters. These theories would be consistent with the effects of atomoxetine, imipramine, and stimulant drugs. Genetic factors may play a significant role. So, the management overview. Multiple strategies may be employed to manage ADHD. In addition to drugs, which are considered first-line treatment, the management program can include family therapy, parent training, and cognitive therapy for the child. Guidelines issued by the American Academy of Pediatrics emphasize the importance of a comprehensive treatment program involving collaborative and collaboration among clinicians, families, and educators. For long-term gains, a combination of cognitive therapy and stimulant drugs appears to be most effective. Again, of these drugs employed for ADHD, stimulants are the most effective and therefore are considered agents of choice. The non-stimulants, atomoxetine, guanfacine, and clonidine, are less effective than stimulants and are therefore considered second-choice drugs. That was strictly speaking in children. However, ADHD in adulthood In about 30 to 60% of cases, childhood ADHD persists into adulthood. In the US, there's about 8 million adults that are afflicted, although an estimated 90% are undiagnosed and untreated. Symptoms include poor concentration, stress intolerance, antisocial behavior, outbursts of anger, and inability to maintain a routine. Also, adults with ADHD experience more job loss, divorce, and driving accidents. So, as a result, as in childhood ADHD, therapy with a stimulant drug is the foundation of treatment. Methylphenidate is prescribed most often, and about 33% of adults fail to respond to stimulants or cannot tolerate their side effects. For these patients, a trial with a non-stimulant may be helpful. Combining behavioral therapy with drug therapy may be more effective than just drug therapy alone. So, what drugs can we use for ADHD? Well, the first choice is our CNS stimulants. Stimulant drugs are the mainstay of ADHD therapy. Drugs with proven efficacy include your methylphenidate, your dexmethylphenidate, dextroamphetamine-amphetamine mixtures, and lisdexamphetamine. So those would be our Ritalin, Concerta, Focalin, Adderall, and Vyvanse. There are no data to support use of one stimulant over another. If one stimulant is ineffective, another should be trialed before considering a second-line agent. The response to stimulants can be considered dramatic. These drugs, again, can increase attention span and goal-oriented behavior while decreasing impulsiveness, distractibility, hyperactivity, and restlessness. Tests of cognitive function often improve significantly. Unfortunately, although benefits can be dramatically initially, in children they diminish after 2 to 3 years. According to a paper in 2009, the MTA at 8 years, prospective follow-ups of children treated with a combined type ADHD in a multi-site study. Nonetheless, stimulant therapy can still buy time to teach children the behavioral strategies to help them combat inattention and hyperactivity over the long term. Although reduction of impulsiveness and hyperactivity with a stimulant may seem paradoxical, it isn't. Stimulants don't suppress rowdy behavior directly. Rather, they improve attention and focus. Impulsiveness and hyperactivity decline because the child is now able to concentrate on the task at hand. It should be noted that stimulants do not create positive behavior, they only reduce negative behavior. Again, accordingly, stimulants cannot give a child good study skills and other appropriate behavior. Rather, these must be learned when the disruptive behavior is no longer an impediment. Principal adverse effects of all stimulants are insomnia and growth suppression. Insomnia results from CNS stimulation and can be minimized by reducing the size of the afternoon dose and taking it no longer than 4 p.m. Growth suppression occurs secondary to appetite suppression. Growth reduction can be minimized by administering stimulants during or after meals. In addition, some clinicians recommend taking drug holidays on weekends and in the summer. However, other clinicians argue against this strategy because depriving children of medicine during these unstructured times can be hard on them. When stimulants are discontinued, a rebound increases in growth will take place, and as a result, adult height may not be affected. Other adverse effects, however, include headache and abdominal pain, which have an incidence rate of 10%, and lethargy and listlessness, which can occur when dosage is excessive. Which brings us to our non-stimulants. There are several non-stimulants that are used for ADHD, although only 3 of them, atomoxetine, guanfacine, and clonidine, are approved by the FDA at this time. The non-stimulants are less effective than the stimulants and are therefore considered second-choice drugs. For the treatment of ADHD, the non-stimulants may be employed as monotherapy or as an add-on therapy with a stimulant. Unlike the stimulants, the non-stimulants are not regulated as a controlled substance. So let's talk about atomoxetine, a norepinephrine uptake inhibitor. Atomoxetine, or Strattera, is a unique drug approved for ADHD in children and adults. It was the first non-stimulant approved for ADHD and one of only three drugs approved for ADHD in adults. The others are amphetamine, dextroamphetamine mixture, or Adderall, and lisdexmethamphetamine, or Vyvanse. In contrast to the CNS stimulants, atomoxetine has no potential for abuse and is therefore not regulated as a controlled substance. So as a result, prescriptions can be refilled over the phone, making atomoxetine a more convenient than these stimulants. Like the long-acting stimulants, atomoxetine can be administered just once a day. In clinical trials, comparing atomoxetine with a placebo in children or adults with ADHD, atomoxetine was clearly superior at reducing symptoms. It should be noted that responses developed slowly. The initial response takes a few days to develop, and a maximal response is seen in 1 to 3 weeks. Thus, contrast with a CNS stimulant whose effects are near maximal with the first dose. So, how does it work? Atomoxetine is a selective inhibitor of norepinephrine reuptake, and therefore causes norepinephrine to accumulate at synapses. Although the precise relationship between this neurochemical action and symptom relief is unknown, it would appear that adaptive changes that occur after uptake blockade underlie benefits. Uptake blockade occurs immediately, whereas full therapeutic effects are not seen for at least a week, suggesting that after uptake blockade occurs, additional processes must take place before benefits can be seen. Its pharmacokinetics. Atomoxetine is rapidly and completely absorbed after oral administration. Plasma levels peak in 1 to 3 hours, depending on whether the drug was taken with or without food. Atomoxetine is metabolized in the liver primarily by CYP2D6, which is an isoenzyme of the cytochrome P450. For most patients, the half-life is 5 hours. However, for about 5 to 10% of the patient population, the half-life can be longer, which could include up to 24 hours. These patients have an atypical form of CYP2D6, which again metabolizes atomoxetine slowly. Dosage should therefore be reduced in this patient population who have that atypical form. So what kind of adverse effects do we have? Well, similar to CNS stimulants, atomoxetine is generally well tolerated. Again, in clinical trials, the most common adverse effects were GI reactions, dyspepsia, nausea, vomiting, a decline in appetite, dizziness, somnolence, mood swings, and trouble sleeping. Sexual dysfunction and urinary retention were seen in adults. Severe allergic reactions, including angioneurotic edema, occurred rarely. If allergy develops, patients should discontinue the drug and contact their prescriber immediately. Atomoxetine may cause suicidal thinking in children and adolescents, but not in adults. Fortunately, the incidence is relatively low, about 4 cases per 1,000 patients. Risk is greatest during the first 3 months of treatment. Young patients should be monitored closely for suicidal thinking and behavior and for signs of clinical worsening. Appetite suppression may result in weight loss and growth delay. Among children who took atomoxetine for 18 months or longer, mean height and weight percentages were in decline. Because experience with the drug is limited, we don't know if expected adult height will be affected, nor do we know if the drug holidays would have an effect on growth. Atomoxetine poses a small risk for severe liver injury that may progress to outright liver failure, resulting in death or the need of a liver transplant. Patients should be informed of signs and symptoms of liver injury and be instructed to report these immediately. In the event of jaundice or a lab evidence of liver injury, the medicine should be discontinued. Atomoxetine may raise or lower blood pressure. During clinical trials, again, some patients had an experience of an increase in blood pressure and heart rate, others had a decrease. During post-marketing surveillance, some patients experienced hypotension and syncope. Patients should be informed of the possibility of both and be advised to sit or lie down if they feel faint. Its drug interaction, again, we mentioned this a little bit already. The inhibitors of CYP2D6, again, can increase levels of atomoxetine and therefore must be used with caution. So medications, for example, are Paxil, Prozac, and quinidine. Its role in ADHD therapy, therefore, again, it's recommended for the treatment of ADHD in cases in which there may be a concern for stimulant abuse or there exists a strong aversion to treatment with stimulant medication. Because CNS stimulants are more effective and have a long record of safety and efficacy, it would seem prudent to reserve atomoxetine for patients who are unresponsive to or intolerant of the stimulants. In the absence of a compelling reason, patients doing well on a stimulant should not necessarily switch. Alpha adrenergic agonists. Two alpha-2 adrenergic agonists, guanfacine and clonidine, again, are also approved for ADHD. Both drugs appear less effective than a CNS stimulant. The principal side effects are sedation, hypotension, and fatigue. Unlike the CNS stimulants, guanfacine and clonidine are not controlled substances and do not cause anorexia or insomnia. Again, these drugs were discussed in Chapter 15, so if you want to see the more basic pharmacology behind them, jump to Chapter 15 for them. Guanfacine. It is available as an extended release formula sold as Intuniv. It is used in treating children and adolescents with ADHD. In clinical trials, the extended release guanfacine improved hyperactivity and inattention. Benefits were greater than with a placebo, but less than reported with a stimulant. Guanfacine activates the presynaptic alpha-2 adrenergic receptor in the brain. However, we don't know how this action relates to the clinical benefits. Principal side effects are somnolence, fatigue, and a reduced blood pressure. Effects on blood pressure are most pronounced during the initial therapy and whenever dosage does get increased. Abrupt discontinuation may cause rebound hypertension. In contrast to stimulants, guanfacine causes weight gain rather than weight loss, causes somnolence rather than insomnia, and is not regulated under the Controlled Substance Act. Because the drug does not cause anorexia or insomnia, it might be especially good for children who cannot tolerate these side effects when taking stimulants. Guanfacine can also be combined with a stimulant to treat severe ADHD. Which brings us to clonidine. Extended release clonidine, or CAPV, is much like ER guanfacine and Intuniv. Both drugs, again, are alpha-2 agonists. Both were developed for hypertension and both have been used off-label in ADHD for years. During clinical trials of ADHD, your extended-release clonidine was superior to a placebo when used alone and provided additional symptom relief when combined with a stimulant. As with guanfacine, principal side effects are somnolence, fatigue, and hypotension. Somnolence can be made worse by alcohol and other CNS depressants. Hypotension can be made worse by antihypertensive agents. Because clonidine can lower blood pressure and heart rate should be measured at baseline, followed by each dose increase and periodically thereafter. Like guanfacine, clonidine does not cause anorexia or insomnia and is not a controlled substance. That concludes our chapter here today. As always, I thank you for listening, and I'll see you at the next one. Take care, and goodbye.